Hi, very good morning to all of you. We warmly welcome you on this Sunday to another webinar co-organized by Shri and GMOA in collaboration with College of Anesthetists and College of Intensivists. Today's topic is a timely one, hypertension in the emergency department. Before we begin, let me remind you of our housekeeping rules. The webinar link will be available from 9 a.m. to 9:45. No late attendees will be permitted thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. And these rules are implemented and to maintain the standards of the CPD program conducted by Shri and GMOA. And we thank you for adhering strictly to the CPD regulations. And if you have any questions during this webinar, you can send them all to the chat box and they will be answered at the end of the webinar. And please be kind enough to switch off your cameras and mute your microphones so that there won't be any interruptions. And thank you all for joining us today. So without further ado, I would like to introduce our guest lecturer, Dr. Tharanga Wijethilaka. She is a lecturer in Department of Anesthesiology and Critical Care at University of Peradeniya, who is also an acting consultant emergency physician, and she will be joining us today via Zoom amidst a busy schedule. Good morning, dear ma'am, and over to you to commence today's webinar.
Hello, and good morning to all of you. So without actually wasting a lot more time, because time is very important to all of us, we'll start the lecture proper today. Okay, so today we are going to talk about hypertension in the emergency department. Now, if you look at the world over, the global burden of hypertension is such that about 31% of the population is suffering from hypertension. So that is 1.28 billion adults between the ages of 30 and 79. Out of them, 2/3 live in low and middle income countries like ours. 46% of them are unaware that they have hypertension. 42% get diagnosed and treated, but only 21% has it under control. Now, hypertension is a major cause of premature death worldwide. If we move on to the Sri Lankan statistics, in our country, the morbidity and mortality is such that our annual morbidity due to essential hypertension alone stands at 97,885. Then hypertensive heart diseases contribute to 7,000 plus deaths. There are some other hypertension-related diseases contributing to a further 2,500 deaths per year. Now, the topic today is hypertensive emergencies. Now, I need to be very clear. We're not going to talk about hypertension per se, because that's a very vast topic. Me being an emergency physician, I would concentrate today's talk mainly on hypertensive emergencies. Now, out of the 1.3 billion who have hypertension, 1 to 2% will suffer a hypertensive crisis in their lifetime. Men are more likely to suffer hypertensive emergencies more than women, and it's more common in older patients. If you take the USA, nearly 24% of ED visits are directly related to hypertension and is rising by 5% annually. In Sri Lanka, the data are quite the same. And over the last couple of weeks or months, we've been seeing increase in number of hypertension-related admissions to our departments. So today, this is what we are going to do. We are going to see how to diagnose hypertension. Then we are going to also see what a hypertensive emergency is what a hypertensive urgency is. Then we'll talk about management of hypertensive emergencies. There are a wide variety of presentations. Some of them need to be managed in a very specific way. We'll talk about what drugs are the best options of treatment. Those were the questions you all also had. And then I'll talk about few special circumstances, including pregnancy, pediatrics, and sympathomimetic overdose. I thought I'd talk a little bit more about pregnancy because given the situation of the country, more and more of our patients are having problems of getting their medications, also finding transport to and from hospitals. As a country, we have been performing very well regarding our preventive medicine and our maternal care. But now, due to our fuel shortage and the current lack of resources, pregnancy is increasingly presenting to emergency departments with a primary delay. So at the end, we'll summarize what we have done and then we'll go through the questions and try and answer them. The first thing is how to properly diagnose hypertension. To diagnose properly, we should take the measurement properly. So we should be having, when you want to check somebody's blood pressure, make sure they're non-smoking, they haven't taken caffeine, food, or they haven't exercised over the last 30 minutes. So they should be quietly sitting down for a minimum of 30 minutes before you check the blood pressure. The patient should be in a quiet room, a comfortable temperature, then 3 to 5 minutes rest after you coming into the doctor's chair, no talking during or between measurements. Get the patient to sit down on a chair with a back support. Get the arm to rest on a table. The BP cuff should be at the level of the heart. Feet should be flat on the floor, and you take 3 measurements at 1 minute interval and use the average of at least 2. Now, one of the things that we have seen commonly is we get patients transferred saying blood pressure 180 over 110 or very high numbers. But when you check again, it's not that high. It's somewhere just beyond the normal level. So never ever treat your patients with one single reading. So how do we diagnose hypertension? So classically, we've been diagnosing hypertension like this. If your systolic blood pressure is equal to or above 140 millimeters mercury, and or your diastolic blood pressure is over or equal to 90 millimeters mercury, you have to repeat it. What they say now is that over a course of 1 to 4 weeks, take about 2 to 3 visits and then diagnose hypertension. This used to be 4 hours apart before, but according to the latest or the 2020 guidelines, what they say is give them some time and get your blood pressure readings. Okay, so one of the things that you could employ is maintaining a blood pressure diary. So that is the classical way of diagnosing hypertension. But now, in a single visit, you could diagnose hypertension. I'm not talking about hypertensive emergency, but pure hypertension. If your blood pressure reading, when I say the reading, it means this average of 3 measurements. Right? If that is above or equal to 180 over 110, with evidence of cardiovascular or other organ damage during a single visit, you could diagnose hypertension. Now, this is actually a good indication to transfer a patient from a peripheral hospital to a sort of a central hospital, because this pressure associated with target organ damage represents hypertensive emergency. So we diagnose hypertensive emergency on the basis of two things. One is the blood pressure number, which is above 180, 120. Now, before I said, now in the previous year, I said 180 over 110. Here I have mentioned 180 over 120. You do not need to stay, you do not need to take these numbers very strictly. What the definition would tell you is a severely elevated blood pressure, usually above the range of 180 over 110 to 120. So if you have that very high number, and if you have presence or worsening of end organ damage, we should make the diagnosis of a hypertensive emergency. So you need to have a high number, and also you need to demonstrate end organ damage. The latest term for these end organ damage is hypertension mediated organ damage, which could be chronic or acute. Now, there are two terms under hypertensive emergency. True hypertensive emergencies and hypertensive urgencies. Now, if you have a substantially elevated blood pressure, that is 180 over 110 to 120, with acute hypertension mediated organ damage, that's a true hypertensive emergency. You need to manage that patient with IV medications. Whereas if you have a significantly elevated blood pressure, but no target organ damage, that's a hypertensive urgency. So you manage that with oral medications. Right, so this is the definition. For practical purposes, if you remember, very high readings with any target organ damage is hypertensive emergency, and just a very high reading is a hypertensive urgency. That will be enough. The difference is how you manage them, your targets of treatment, and your timeline. So true emergencies, we go for IV medications. Urgencies, we manage with oral medications. What are the risk factors? What tells us that your patient is at a high risk of hypertensive emergency? The leading cause worldwide and in Sri Lanka, especially over the last couple of months, is inadequate treatment. Now, our patients face two things. They may be inadequately treated, or they may have financial problems in getting their medications, thus inadequately treated. As doctors, we should be focusing a little bit more on provision of medications that our patients can afford to minimize this. So inadequate treatment is the leading or the most prevalent cause of a risk factor for a hypertensive emergency worldwide. Chronic kidney disease, again, quite prominent, quite prevalent in our society. Renal artery stenosis, renal transplants, endocrine disorders with known hypertensive effects, obstructive sleep apnea, and vasculitic and connective tissue diseases are the other risk factors. These are quite, the prevalence-wise, these things are not that common to find, but these two, very common in our situation. Right, so we spoke about what a hypertensive emergency is and what a hypertensive urgency is. What does malignant hypertension mean? So now, if you look at the number, it has gone beyond 200. So severe blood pressure elevation above 200/120 associated with advanced bilateral retinopathy. So if you have a blood pressure reading which is sky high, and then when you look at the eye, you see papilledema, cotton wool spots, hemorrhages. So that is advanced retinopathy associated with hypertension. In malignant hypertension, you have this very high number associated with usually retinopathy. What are the other organs? Now, eyes, yes, we know that the eyes get affected with hypertension, and in an acute hypertensive emergency, most of the organs that are chronically affected by hypertension get affected. So these target organs are retina, brain, heart, large arteries, kidneys, and your lungs. In the brain, you could have several things, including hypertensive encephalopathy, intracranial hemorrhages, then you can have ischemic strokes. In the eyes, you could have hypertensive retinopathy. In the lungs, you could have hypertension-mediated acute pulmonary edema. The heart can get angina-like pain, acute myocardial infarctions. The heart can actually go into a high output cardiac failure. Then you can, in the vascular system, you could have an arterial dissection, and the kidneys can actually pack up and go into acute renal failure. Now, let's talk about each of these target organs in a little bit of detail, because patients don't come and tell us, doctor, this organ is involved. We should be able to pick it up. Right? So the first organ we'll look at is the brain. So how can a brain hypertensive emergency present? It can present as a TIA or a stroke. The symptoms patients will tell us would be quite similar to the symptoms of a stroke or an ICH. So vision changes, dizziness, headaches. Now, you would have seen most patients complain of headache when they have hypertension, and we generally think headache is associated with hypertension. But theoretically, the studies have shown is if you do have headache, that sort of points towards development of hypertensive encephalopathy. So headaches, dysarthria, seizures, altered mental status, dysphagia, loss of sensation or paresthesia, loss of movement. These are all signs of a focal neurological impairment, which is telling us indirectly that the patient could be having a TIA or an ischemic stroke or ICH. So what do? We should image these people who come in with these symptoms, also meeting criteria for hypertensive emergency. We must image them before starting treatment, because how we treat each condition is different. The standard investigation that we would do is an NCCT brain, non-contrast CT brain. Next most important thing comes in management, but we'll talk about it later. Now, we say the standard of care in our country is NCCT brain. But having said that, it's good to know that MRI can detect early and subclinical changes, especially changes of hypertensive encephalopathy, because you can't see any structural change due to hypertensive encephalopathy in NCCT brain. Uncontrast CT brain is good to detect bleeds, also ischemic strokes. The MRI, if you get the privilege to do it, would detect white matter lesions, silent microinfarcts, microbleeds, and also cerebral atrophy. Right, so that's about the brain. Then we'll look at the heart. Now, in Sri Lankan statistics, we said about beyond 7,500 patients die each year in Sri Lanka due to hypertension-mediated heart diseases. So when you have acute hypertensive emergency presenting as a cardiac emergency, the two things most prevalent are acute myocardial infarction and acute heart failure. Usually, acute heart failure is associated with a pulmonary edema as well. Now, if your patient is complaining of these things, chest pain, shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, palpitations, edema, murmurs, rubs, third heart sound, elevated JVP. So these are all suggestive of an acute cardiovascular disorder. If their chest pain is retrosternal, tightening type, associated with nausea, vomiting, radiating to the left arm, jaw, neck, you must be thinking, okay, is it an anginal pain? Then what do we recommend? We recommend do an ECG within 10 minutes. Let's see, you got the ECG. The ECG shows an SD elevation, probably in the inferior segment, inferior territory, we'll say. What if the patient does have an angina, typical angina chest pain, but the patient also tells you my pain goes tearing through to my back and it hurts between my scapulae, or in other words, interscapular pain. So that should ring a bell in your head. Now, this guy has criteria to meet hypertensive emergency. He also complains of a typical ischemic chest pain. But there's an added thing. The chest pain radiates to the back. So you must think of dissection of coronary arteries as the cause, as the pathological cause of the MI as well. So hypertensive emergency involving the heart can have a type 2 MI or a supply-demand kind of an MI, or pathologically can directly relate to a dissection of coronary arteries, a proximal extension of an aortic dissection. Why is it important to know? It's important because we treat it differently. The practice in our country, in those hospitals who are privileged enough to process fibrinolytics or thrombolytics, is to go for thrombolysis, because when you consider transit times, achieving primary PCI for all patients is not possible. So you must, when your patient has ischemic chest pain, ECG consistent of acute STEMI, if the patient says pain radiating to back, interscapular pain, the most important thing you must do is check blood pressure on both arms. Look for radial delays or radiofemoral delays. If you do suspect a dissection, you must take it further from there rather than treating, because we cannot be giving fibrinolytics to patients who have dissections. So the things that you could do is do a chest X-ray, look for mediastinal widening. If you do have that, you must escalate to do a CT thoracic angiography or a CT aortogram. So if the patient does not complain of pain radiating to back, if there is no blood pressure difference, if there is no radiofemoral delay, you could thrombolize your patient. But there's another problem. Now, he's in a hypertensive emergency. The blood pressure is sky high. Is it safe to administer a fibrinolytic agent to a patient like this? What the guidelines tell us is you must get your blood pressure down to a safer level before you initiate thrombolytics. We'll talk about the numbers. when we talk about management. Right, so we spoke about the heart, then we're going to talk about the eyes. Now, hypertensive retinopathy can be, it's quite graphical, I would say. So arterial spasms, retinal edema, retinal hemorrhages, retinal exudates, microaneurysms, papilledema, and engorged neck, retinal veins. So basically, you would see dot blood hemorrhages, what you see here, then multiple cotton wool spots, exudates, there, can you see? And then you have macular exudates. So it's a good thing actually to learn to check the eyes in patients with hypertension. It's actually quite a good thing because it's cost effective. You don't need high-fi investigations. You just need a fundoscope, which is pretty much available in any hospital. And you could have a printed set of pictures to analyze what you see. Right. Then if you look at the kidney, now renal diseases is quite prevalent in our country. Acute hypertension or hypertensive emergency may present as acute renal failure. It may present as acute and chronic renal failure as well. The patients can have oliguria or polyuria depending on how their renal disease is. But if the patient has a hypo or like oliguric renal failure, it is more evident to us. We would detect it early. The other things we would see would be raised serum creatinine, urine would show proteinuria, active sediments, and it's always good to check the retina because these two go together. Kidney and the eye involvement goes together. Right. Then we talk about the major arteries or the aortic dissection per se. Now, this is aortic dissection per se, right? Aortic dissection can involve your proximal aorta or your distal aorta or both, or include the arch. So there are different ways of categorizing the involvement. Now, severe hypertension can present as an aortic dissection. The usual clinical symptoms would be chest pain, radiating through to the back. They would also complain of two system involvements, like you've got the chest pain, which is typical. And also you have confusion or altered level of consciousness. That is when your dissection involves your carotids, like the blood supply to the brain is now involved. Then the patient can have abdominal pain. So two system involvements, severe hypertension, you must think of aortic dissection. Objectively, how do we detect it? We detect it if you have a blood pressure difference in your bilateral arms. Now, this is more than 20 millimeter mercury difference refers to the systolic blood pressure, right? So now it's important to check the blood pressure correctly. It's important to take repeated readings, but it's also quite important to record blood pressure in both arms, particularly if you have a patient complaining, I have a chest pain that goes to the back of my chest. Now the pain is sort of tearing and I've got an interscapular pain. So that patient, you must have a high index of suspicion for an aortic dissection. These patients deteriorate quite rapidly, very rapidly. So one of the investigations you could do now, if you look at this X-ray, it says mobile. So at least the big hospitals have the facility to take chest X-rays wherever the patient is. So this is one of the things that you could do. Right. So, okay. So those are the target organs that can get involved in true hypertensive emergencies: brain, eyes, lungs, CVS, kidneys. Okay, now let's see how these patients commonly present with hypertensive emergencies. So patients can commonly come with hypertensive encephalopathy. So they've got a very high blood pressure number associated with lethargy, seizures, cortical blindness, and coma in the absence of other explanations. So you don't have a stroke or an ICH. The NCCT brain is pretty much not showing anything, but the patient has a severely elevated blood pressure and some neurological symptoms. Then there is this other entity of hypertensive thrombotic microangiopathy. What's that? So this is a hematological manifestation. So you've got severe blood pressure elevation associated with hemolysis and thrombocytopenia, like a DIC, in the absence of other causes, and it improves when the blood pressure improves. This is actually not a very common thing to see, but it's a grave thing to miss, actually. Then, commonly in our country, people present with cerebral hemorrhages due as hypertensive emergencies. Very common to see this. Acute strokes are quite common. Now, again, just like in your myocardial infarctions, like here, acute coronary syndrome, it's very important. Now, as some of you may be aware, in Sri Lanka, we try and fibrinolyze. So we administer thrombolytics to acute strokes and acute coronary syndromes. Now, if it is a hypertensive emergency, we have to be quite careful before we administer the medication to control the blood pressure. We need to bring down the blood pressure to a safer level before we administer the thrombolytic, because the risk of converting into a hemorrhage or an ICH. So then commonly we see this cardiogenic pulmonary edema, quite common. Aortic aneurysms, not that common, but we see a number of patients on and off, and eclampsia and severe preeclampsia. These things we have to be aware, especially now, because of the prevailing situation in the country. Right. Okay. So in the history, when you have a patient coming to you with any of the symptoms discussed up to now, we must ask them about pre-existing hypertension, onset and duration of symptoms to determine whether this is an acute problem or a chronic problem. Then we have to figure out why, or the potential causes. Now, those of you who work in PCOs, OPDs, you would come across so many, or even medical clinics, you would see quite a number of patients who present. They come to you, you check their blood pressure, and the blood pressure is high. When you inquire, they don't really give you any symptom as such. They may complain of a little bit of headache, but nothing further. If you dig into the cause, non-adherence with prescribed antihypertensive drugs is a very, very common thing. One of the reasons is because of the drug shortage and people are asked to buy from outside. One of the reasons is that, but some patients don't really understand that they need to take the antihypertensives regularly, although their blood pressure is now okay. You must tell them, or you must give the health education to them, saying, your blood pressure is normal because you have been taking your medications regularly. One other thing is, when you change or interchange the antihypertensives, again, you need to tell the patient, because sometimes patients, if you don't tell them your antihypertensive medication has been changed, they would think the doctor made a mistake and I was given a completely wrong medication, which I will not take. It's common these days, we very commonly see this. Okay, right. This actually started with the COVID. We started sending medications to patients as opposed to seeing them every month. So we wanted to continue the care, and we started sending the patients medications, and now they're so used to it, they don't come to clinics anymore, right? So, right, okay. Then lifestyle changes. What has happened in their life? So one of the things that I commonly saw is that they have changed where they live because they can't travel, or the children are having trouble looking after kids. Financially, they're having trouble. So people have changed the place they live, and now they can't go back to the clinic. So they have just stopped taking medications, or they would just take the book to a pharmacist, get the medications without checking their blood pressure. Right, then potential cause for to present with severe hypertension is a concomitant use of a BP elevating drug like an NSAID, a steroid, an immunosuppressant, sympathomimetics, commoner among the younger age group, especially because now drugs of abuse are quite abundant in our country, all over the country. And due to a shortage of some of the commoner agents, our population who take substances, who abuse substances, have shifted to taking sympathomimetics. People who take cocaine, they can present with these devastating hypertensive emergencies. They can present with acute myocardial infarctions. Then anti-angiogenic therapy. This is not very common. Right. So that is the elements of all the things that you have to inquire in the history. Like you need to ask them these questions. When you move on to the examination, we pretty much should do a good cardiovascular system examination. What is meant by a good CVS examination is you actually check the pulses, the peripheral pulses. You look for pulse deficits, radioradial delays, radiofemoral delays. You check the blood pressure in the proper way, get them to sit, relax, take a couple of readings, take the average. Also check blood pressure in both sides. Then auscultate the heart, try and pick up these friction rubs, S3s, new onset murmurs. The neurological examination, again, very important. Neurological examination to detect focal neurological signs. And as I told, fundoscopy is, again, quite an important bedside test that you must practice, I would say. Okay. So, right, you've got the history, you've got the examination. Now, we have what investigations should be considered. Now, when you go through the history and examination, by now you know the blood pressure is over 180 and 110, and they have some symptoms. So we have the diagnosis as hypertensive emergency. We've got a clinical diagnosis. Now, to prove it, we have to do some investigations. So the first line diagnostic investigations would be a full blood count. Now, I have put a blood picture here, not because it's that common for us to see hypertension-mediated thrombotic presentations, or DIC, hypertension-mediated microangiopathic hemolytic anemia. That's not a common thing to see, but if your patient has the symptoms suggesting that, you must order the blood picture as well. Then serum electrolytes, very important in our setting because chronic renal failure is quite prevalent, and you see patients presenting with acute on chronic renal failure. So renal functions are important. Urine analysis is important. Now, one of the things that you must remember is in our government sector, we've got dipsticks, which are not used that prevalently, like we don't use it that often. Even in developed countries, Urine dipstick is a pretty much bedside test. It's cost effective, gives you the result rapidly. And if you actually look at the costing to do a UFR versus doing a urine dipstick, it's actually it's very, very cost effective. So available in the government, available from our government as well. Right, so what do? We look at the urine to look at proteins and active sediments. Then an ECG is very important, also a chest X-ray. Chest X-ray can help us in two ways. So one of the things you would see with hypertension is your hypertensive cardiomegaly, or you could see the aortic dissection or the vascular aspect of it. So the second line things are more pointing towards the etiology, things like thyroid function tests, cardiac enzymes, if you are thinking of an myocardial infarction, CD thorax aortogram or transesophageal echocardiogram when you think of aortic dissections, renal ultrasound scan with Doppler, and also this is more related to the acute renal failure, NCCT brain. And if your patient is pregnant, there's a number of tests that you would do in those patients, which we will discuss separately. Right, so basically, hypertensive emergencies are like this, right? This is the summary of all that we have done up to now, right? So you can have hypertension causing renal damage, hypertension causing brain damage, which can present as encephalopathy, stroke, or hemorrhage. Then you can have acute coronary events, acute cardiogenic pulmonary edema. You can have aortic dissections, and then if your patient is a pregnant lady, you could have eclampsia, severe preeclampsia, or HELLP syndrome. Now, what we must remember is in any of these emergencies, we use IV medications. Each of these conditions have a dedicated targeted treatment, right? Now, if you take your aortic dissection, that is the hypertensive emergency, which needs to be treated as early as possible. You bring down the systolic blood pressure to less than 120 and the heart rate to less than 60 within 5 to 20 minutes, they say. It used to be 5 minutes. Now what they say is up to 20 minutes. Within 20 minutes, it should be below 120, 80, heart rate less than 60. When you have a pregnant lady, severely elevated blood pressure, urine proteinuria, hyperreflexia or hyperexcitability, immediately get the blood pressure down to a safer level, which is systolic less than 160 and diastolic less than 105. These people, pregnant ladies in eclampsia, severe preeclampsia or HELLP syndrome, we need to liaise with our GynObs team, obstetric team, and terminate the pregnancy as early as possible. Then we have the brain. Now, if it is bleeding, we need to get the blood pressure down only to less than 180. We just prevent it from bleeding further, right? In acute ischemic strokes, we are not that strict on our blood pressure control. Now, I'll tell you why that is when we talk about the management there. In hypertensive encephalopathy, immediately you bring it down, and in renal involvement, you can take few hours and bring it down to by 20 to 25%. These are the agents recommended. We'll talk about each agent with each presentation. This, I think, is the most important aspect in today's talk, because we would We would all possess the knowledge. It's just a recap for all of us how to diagnose. So general principles are, for hypertensive emergency management, initial goal is to drop the blood pressure by not more than 25% within minutes to hours. So we don't go and bring the blood, unless otherwise you have an aortic dissection. All the other conditions drop by not more than 25% within minutes to hours. So generally we get this 25% drop within the first 5 minutes, up to the first hour. Then if the patient is stable, we consider lowering the systolic to 160 and diastolic to this 100 to 110 range within 2 to 6 hours. We try and normalize the blood pressure in hypertensive emergencies by about 24 up to about 48 hours. So do we need to make SANA? If a patient comes and tells you, doctor, I ran out of the medications. I was at my daughter's place. I couldn't take antihypertensives for the last 2 weeks. And when you check the blood pressure is 180 over 110, but she has no other target organ damage symptom. Do you need to bring the blood pressure down to 140 over 90 drastically? You do not. Now, if this patient presented with an acute ischemic stroke, still do you need to bring the blood pressure down to 140/90? No. You have a time interval. You don't need to bring the blood pressure down immediately. So this is important for us to determine whether your patient needs admission to a PCU or an A&E from the OPD. Do they need or not? Can they be managed in a clinic? Does my patient needs to be transferred out to a big hospital or not? So you go through the history, you identify the cause, you identify the symptoms. We don't just manage patients with BP numbers. Right. So if your patient has malignant hypertension, hypertensive encephalopathy, or intracranial hemorrhage, if we are thinking there is raised intracranial pressure or a renal disease, first line of treatment is labetalol. IV labetalol, 20 milligrams, which is given as a bolus, repeated every 10 minutes, maximum cumulative dose of 300 milligrams. So there is actually no point in giving IV labetalol 5 milligrams, which is next to a nothing dose. If you do have to escalate, you can escalate it into an IV infusion. Right. Even if you are not thinking of raised ICP and your renal functions are fine, you can still go for IV labetalol as the first line or sodium nitroprusside as the second line treatment. Okay. What about, now that is malignant hypertension, hypertensive encephalopathy and ICH. What about acute ischemic stroke? Now, when you have the brain arterial blood flow cut off at some point, you have an ischemic core. Around that region, you have the ischemic penumbra. This bit is already dead. This light orange bit is not dead. It's just ischemic. Why is it ischemic? Because now the artery is now cut off blood supply to this whole area, reduced blood supply to this area. Now, if you look at your brain sits in a confined space, which is the skull. And our skulls are not empty, no, they are full. So the skull volume, 80% of the skull volume is for your brain. 10% for blood, 10% for CSF. There is no free space. If something happens, if any insult happens, what happens to our body? The body swells up or there is edema. So generally, this ischemic penumbra is edematous. Right, now there is edema happening inside a confined space. Inside a tight box, you have edema. Now what happens? Your ICP or intracranial, the volume is confirmed. Volume is the same volume. The skull didn't change, so the volume of the cranial cavity is the same. The contents have changed. The brain has a little bit of edema. Because it's a confined space, the pressure goes up. ICP goes up. Our body physiology is such that the cerebral perfusion pressure is auto-regulated. The brain regulates its blood flow by itself. Cerebral perfusion pressure stays same with a range of, now the blood flow stays at the same level even though your cerebral perfusion pressure has changed from 50 to 150. Why did the CPP change? Because your ICP went up. Your intracranial pressure went up. To maintain the same flow, your CPP or the cerebral perfusion pressure went up. How did it go up? By increasing your mean arterial pressure. So the blood pressure number in an acute ischemic stroke reflects the brain's response to edema in this area. Right? Now, this area is ischemic. What will happen if we bring down the blood pressure? If we bring down the blood pressure, MAP goes down. MAP goes down, ICP is going up, your cerebral perfusion pressure will go down. So you will end up here with further ischemia. That is why we don't generally go for a rapid or a tight control of blood pressure in acute ischemic strokes. Having said that, just if your numbers are very bad, like about 220, you need to treat them. If you're thinking of thrombolysis, you need to get the blood pressure down to a safe level. Having said that, but you don't go for a tight control of blood pressure. Right? So if the systolic blood pressure is above 220 or the diastolic is above 121 to 140, these are high numbers. Go for IV labetalol. If only your diastolic is high, you could try nitroprusside. If your systolic blood pressure is less than 220, diastolic less than 120, you can observe. But if you are going for a thrombolysis, you must get down your systolic blood pressure to less than 185, diastolic blood pressure to less than 110 to start your thrombolysis. And during thrombolysis, we bring it down by a further 5 millimeters mercury. Those of you who are working in neurology units, especially in the teaching hospitals, you will be handling a thrombolysis of acute ischemic strokes. You'll be monitoring these patients, administering thrombolytics. So these are your treatment targets. But if you're not going for a thrombolysis, if the blood pressure is less than these numbers, you could observe. And you don't need to get a very tight control. Clear? Right. Okay. Right. So what about MIs, myocardial infarctions and ischemias? First line treatments are esmolol, again available in Sri Lanka. GTN, very commonly available. If you can't find esmolol, don't worry about it. You can easily use GTN. GTN is a vasodilator. So it's a coronary vasodilator as well. So actually it's quite beneficial to give in myocardial infarctions. So generally we go for an IV infusion. It's not weight dependent. There is no relation to the weight. It just goes as micrograms per minute. You start at 5, double every 5 minutes up to a maximum of 100. Right? And there are very special instances where you could go up to, we could double this maximum dose, but I would suggest you need a specialist opinion before you do that. And very easy to remember. Start at 5, double every 5 minutes, and go up as you need. Very beneficial in myocardial infarctions, acute cardiogenic pulmonary edema, and renal failure due to this vasodilatory effect. So first line is that, second line labetalol, third line is nitroprusside. Again, the same theory applies for myocardial infarction management. So if you're going to thrombolize them, you need to get the blood pressure down to a safe level, right? So the agent you would use wouldn't be labetalol as the first choice. You would be using GTN, but get the blood pressure down to a safe level before you administer a thrombolytic for a STEMI if they have concomitant hypertension. Right. So what about if they're going for a PCI, primary PCI? Again, the blood pressure needs to be at a safe level. Discuss that with your cardiologist. Further, I need to tell you about the ICHs. Now, ICHs also, I said, we need to get the blood pressure down to a safe level, intracranial hemorrhages, because this is important. Even if you go for now this raised ICP, they might end up neurosurgeons operating on them, right, for ICHs. So getting the blood pressure down to a safe level is very, very important in order to give them anesthesia as well, right? Okay. Right. Right, now we come to left ventricular failure and pulmonary edema. So what is pulmonary edema? That is fluid outside your blood vessels, but in the lungs, basically wet lungs. What can we now? The alveoli are full of water. Blood pressure is sky high. Patient is now having shortness of breath, orthopnea, reduced, they are hypoxic, and their respiratory rate goes up. What can we do now? We can use, for this hypertensive emergency, we use a combination. So first, now we need to figure out, okay, what is the pathology? They've got wet lungs. How am I going to make it dry? And how am I going to get rid of this extra fluid? So medications wise, an agent that dilates pulmonary vessels is better. So your GTN becomes the first line. And how to get rid of extra water from the body? You use furosemide. What you need to remember is edema is extravascular fluid. It's not in the blood vessels. Furosemide, being a loop diuretic, gets rid of your intravascular fluid. So whatever you do, you must try and get this extravascular fluid into the blood vessels before you start furosemide. Otherwise, you'll be just taking water from inside the vessels, where the problem actually is fluid outside your blood vessels. Right? So commonly, what do? We start these patients on continuous positive airway pressure using a non-invasive ventilator. You increase the pressure, you maintain a PEEP, you push the fluid in the alveoli back into the blood vessels. GTN will make the pulmonary vessels bigger and fluid will come into the vascular system. Then you give your furosemide to get rid of this extra fluid. And that is the principle of treatment of left ventricular failure or hypertensive acute pulmonary edema. Right? So how much of GTN? Again, we go for an infusion. We start at 5 and double every 5 minutes up to about 100. Then furosemide, you can actually go for boluses. You don't need to go for an infusion, but if you prefer to go for an infusion, you could. Because here, now today we are talking about hypertensive failure. So that old school thinking of furosemide making your blood pressure go down, it's actually going to be beneficial for us to go for boluses, 40, 80, increase as appropriately to the maximum dose. Okay, right. So second line agents, if these are not helping, you could go for the second line agents like nitroprusside and furosemide. But now here, when you have pulmonary edema, you can't stop there, right? you need to figure out why they developed pulmonary edema. Why did they go into a failure? It could be ischemic origin, it could be cardiac origin, cardiac ischemia, or it could be renal in origin. Right? So treatment is pretty much the same for cardiac ischemia and for renal ischemia. We would go for the GTN if it is associated with hypertension. But in the long-term management, you must get the primary diagnosis identified. Okay? Right. Now, aortic dissection we have already spoken about. The first line treatment is labetalol. We go for IV boluses, 20 milligrams every 10 minutes. Max dose is 300. That is the cumulative dose. We could go for an infusion. What are the treatment targets? Systolic blood pressure to come to less than 120 within 20 minutes and heart rate to come down to less than 60. These both are important because the more the vessels pulsate, your dissection is going to extend. Right, then you have your kidneys. Again, now we have already spoken about this, quite prevalent in our country. You all have all seen patients like this. So the hypertensive, acute renal failure, GTN is the best option as the first line treatment. Right. Now what we must remember is, now if you have oliguria, it's very easy to detect, right? If there is no oliguria, it might be very difficult to determine whether you're dealing with a chronic CKD or not, right? You can have acute on chronic presentations, no? So what you must remember is these patients, now this is a prevalent disease in our population. So they need individualized approach, specialist involvement, and very close follow-up, right? So if the acute renal failure was just related to the hypertension, it should settle when the hypertension settles. But even now, if once you treat your acute condition, if your renal impairment is persisting, you can't stop there. That patient needs a specialist referral, and that patient needs to be referred to the nephrologist for further follow-up. Right. Now, this is becoming common in our country, not as common as in developed world, but becoming common. Right. So now hyperadrenergic states. The prevalence of pathological hyperadrenergic states is not very common in the country. But now, sympathomimetic drug use is getting more and more prevalent, mostly among our youngsters. And so these sympathomimetic drugs are things like cocaine and amphetamines like ice, meth, crystal, and these kind of things. Now, presentations can be a wide myriad of things, right? Sympathomimetic drugs have quite a lot of effects on the body, one of which is hypertension, malignant hypertension, or severely elevated blood pressure, or hypertensive emergencies. One of those is acute myocardial infarctions, and another one is aortic dissections. What we must remember is the first line of treatment is actually benzodiazepines for most of the conditions. So we generally don't use benzodiazepines in our hypertensive management. So if your patient the patient gives you a history of cocaine use or this amphetamine use, treat them with benzodiazepines. Right? Generally, an agent we could use lorazepam if you have, but diazepam is commonly available in pretty much all the hospitals. So you could go for 5 milligrams IV diazepam, repeated 5 to 10 minutes to a maximum dose of 50 minutes. Again, these patients, better not to manage them in small peripheral units and better to send them to bigger hospitals or central hospitals because they can have devastating or very significant organ involvements and clinical deterioration. Then you could have hyperadrenergic states due to pheochromocytomas and things. Not very common. We manage them in ICUs pretty much, and the agents we use are not commonly available in PCUs or like in general wards. Fentanyl is kind of an ICU type of medication that we use. But you must remember is regarding this hyperrenergic states, it's not actually great to use unopposed beta blockers. Now, labetalol, although it has alpha and beta both, beta effects both, if you give them just beta blockers, you go, because of the hyperrenergic state, you can end up having an unopposed alpha effect. Right? So it's not a great option to treat them with IV labetalol as the first line. It's an adjunct. So that is why they go into the ICU. Right. Okay. That is about hypertensive emergencies, right? So we have treatment targets for each organ involvement. What about managing a hypertensive urgency? Now, this is more common. This is commoner than hypertensive emergency. Basically, what you need to do is reduce the mean arterial pressure or the systolic blood pressure by 10 to 20% in the first hour, right? About 10% is fine. Reduce by a further 5 to 15% over the next 23 hours. So we achieve a 25% drop over 1 day. It's 24 hours now. That is now in hypertensive emergencies, we took minutes to the first hour to bring this blood pressure down by 25%. Here, we take about 24 hours to bring it down by 25%. BP drop not more than 25% in the first 24 hours. In hypertensive emergencies, we say BP drop not more than 25% within the first hour. Right? Okay. Right. Now, to achieve the normal blood pressure or to bring down the blood pressure less than 149, you could take a couple of days even. There's no hurry. So now you can decide which patients, now when you see a patient in the clinic who has high blood pressure, but not fitting into the diagnosis of hypertensive emergency, you can easily diagnose as, okay, this guy has hypertensive urgency. What can we offer them as treatment? Do they need to come into the hospital and stay a few days at the hospital? They don't. They can come to a preliminary care unit. And when you achieve this blood pressure drop by the evening, you could easily discharge them and get them down to the clinic later on. These guys don't need to stay in the hospital unless otherwise they meet criteria for an emergency, or if you think this can easily progress into an emergency. So you don't need to admit all the patients who have higher blood pressure numbers. Right. So this is about the hypertensive emergencies in adults. Right. So now we'll talk a little bit about hypertension in pregnancy. I thought we'll highlight this a little bit more now because of the country's situation. Now, hypertension in pregnancy, it affects 5 to 10% of pregnancies. There are few risks to mother as well as to the baby. Now, if you do have any questions, please, as you were advised, you can put them in the chat, and at the end, we'll talk about it. So, maternal risks of hypertension are placental abruptions, strokes, organ failures. We can go into DIC. Babies can get IUGR, preterm birth, and IUD. Now, all the hypertension seen in pregnancy is not gestational hypertension. You can have pre-existing hypertension. So before pregnancy or before 20 weeks of gestation and lasting beyond 6 weeks postpartum, associated with proteinuria, if you have hypertension, this is pre-existing hypertension. Although it's pre-existing hypertension, it can still cause maternal and fetal adverse outcomes. Gestational hypertension, by definition, starts after 20 weeks of gestation and lasts less than 6 weeks postpartum. Then you have the mixed group. You have the pre-existing hypertension plus superimposed gestational hypertension with proteinuria. Okay, now what is preeclampsia? This is hypertension with proteinuria. when we say proteinuria, it has to be more than 300 milligrams for 24 hours. What are the predisposing factors? Pre-existing hypertension, hypertensive diseases during past pregnancies, diabetes, renal diseases, people who have had renal transplants and all, or has chronic kidney disease, first pregnancy or multiple gestation, then autoimmune diseases. Then if you have, if the mother is, then you can, if the mother is above 40 and also if your pregnancy interval is above more than 10 years, again, they are tied. So what is eclampsia? Now you have hypertension, you have proteinuria, but you also now have hyperexcitability, neurological symptoms like seizures, severe headaches, visual disturbances, abdominal pain, nausea, vomiting, and low urinary output. You must treat immediately and deliver. You have to treat them urgently with IV medications and deliver the baby. Then this can progress into HELP syndrome, where you have hemolysis, elevated liver functions, and low platelets. Again, these patients, you need multidisciplinary approach to these patients. Patients need to be seen by the obstetric team, anesthetic team, or the intensive care team very early. Right. Now, we spoke about what investigations are important in hypertensive emergency in the general public. Here we are going to talk about what investigations are important in pregnancies that are complicated with hypertension. So usually we do the urine analysis now. So you look for proteinuria. If you have proteinuria in early pregnancy, that is more likely to be pre-existing renal disease. Second half of pregnancy, preeclampsia becomes likely after 20 weeks. If you have proteinuria more than 1+, you must follow them up. And then you do a count, liver enzymes, hematocrit, serum creatinine, and serum urea analysis. Now, these are all directly related to the clinical conditions we spoke about. We also do ultrasound of kidneys. If you are thinking of a rare thing like pheochromocytoma, you could do the relevant thing. Then one other important thing is we see how the baby is doing. So we do a Doppler ultrasound of the uterine arteries. Right? So you can detect who are at high risk of gestational hypertension, preeclampsia, uterine growth retardation. We can detect this. Right. So now we spoke about the risk factors to develop hypertension in pregnancy. Now, preeclampsia, highest risk is associated when you have hypertension in past pregnancies, when you have CKD, people with autoimmune diseases, people with diabetes, chronic hypertension. They are at quite a high risk of developing preeclampsia. Then moderate risk, first pregnancy in a woman over 40 years, pregnancy interval above 10 years, obese people, family history, multiple gestations. They are all at risk of development of preeclampsia. So what do we do when we detect it? We start them on aspirin. And if they are low on calcium, they say you could start them on calcium too. Right? Now, today we are focusing more on emergency aspect of it now. So if you have a pregnant lady and their blood pressure is above 150/95, you must start them on treatment. If you have a blood pressure above 140/90, you have to see whether it's gestational hypertension. Now, blood pressure above 140/90 associated with gestational hypertension, pre-existing hypertension with superimposed gestational hypertension, and hypertension with subclinical hypertension-mediated organ damage at any time during pregnancy, they need to be started on antihypertensives. Right? So what are these choices? First line choices are methyl dope. You could use labetalol, you could use calcium channel blockers like nifedipine. Okay. Contraindication, these ones, ACE inhibitors, ARB blockers, we don't generally prescribe to pregnant ladies because there are some adverse fetal and neonatal outcomes. Right? So methyl dopa, nifedipine is commonly available all over the country. So those are the medications you can use. Also, if you have, you could use labetalol. That is mild, right? Now, when you have severe hypertension, if the systolic blood pressure is above 170 and the diastolic is above 110, these ladies needs to be admitted to the hospital. We treat them with IV labetalol. If you do not have IV labetalol, now let's say they came to a peripheral hospital, blood pressure is high, they're complaining of tummy pain, they got a bit of hyperreflexia. So you don't have IV labetalol. If you do have hydrolysine, you can give that. Some units do have esmolol. Otherwise, you can orally give a methyl dopa or a nifedipine. Now, we can't be telling not capsule because we don't have it that commonly. But if you do have non-capsule nifedipine, you can give that. And before transfer, you can give them the medication. Further, if there is severe hypertension and hyperreflexia or hyperexcitability, we give them IV magnesium 2 to 4 grams. That is to prevent eclampsia. And if the patient has pulmonary edema, we can start them on GTN. But we generally try and avoid sodium nitroprusside because of the adverse fetal effects. Right. Now, when do we terminate the pregnancy? Usually, it is just gestational hypertension pre-eclampsia, not really eclampsia or severe pre-eclampsia. We try and after 37 weeks, when the baby's lungs are matured, it's all right. You can expedite delivery when you have visual disturbance or hemostatic disorders, that is your development of DIC. If you have those things, you can escalate. You can terminate pregnancy early. Otherwise, we try and drag it up to 37 and terminate beyond that. Right? That's the decision taken by the obstetrician. Now, then there's another type of patients we see in emergency departments. Now these weeks are important because when the patient comes to you, if they're less than 36 weeks, we know mom has an indication to terminate the pregnancy. But the fetus is not mature enough. The lungs are not mature enough. So it's actually prudent for us to administer the dexamethasone so that we minimize the time delays. We contribute to a good maternal and fetal outcome. That is why I'm just touching upon these weeks, even though today's topic is quite the ED kind of management. And then what about these postpartum mamas who come, postpartum mothers also come? Now, if it is persisting, if the hypertension is persisting, you need to treat them. Right? Methyl dopa is generally avoided because it can result in depression. What about breastfeeding? Now, parents have these concerns. No, mothers, they would ask, I'm breastfeeding. What can happen to my baby? So what you must understand is all antihypertensives are excreted into breast milk, but at lower concentrations. You see higher concentrations of antihypertensives such as atenolol, propranolol, and nifedipine. So generally, we don't give. We generally go for a long-acting calcium channel blocker. Right? Now, what are these long-term consequences of gestational hypertension? You can have increased risk of later on, like in your adult life, mothers can have hypertension and cardiovascular diseases like strokes and ischemic heart disease. So that is about the pregnant lady. So we have by now we have spoken about adults and pregnant ladies. So before I move on, I'll just have a quick look at the chat and let's see what things we have. Right. So for hypertensive urgencies, you can use pretty much any medication because now you don't have any target organ damage. So you can pretty much use any antihypertensive, whatever the patient is already on. Now you can use things like amlodipine. Prazosin is a drastic drug, not a very common drug, not a very good choice, right? So target pressure in STEMI awaiting thrombolysis, pretty much same to your stroke. So you bring it down to less than 180 over 105. Now, thrombolysis in strokes happens over 1 hour. If you are lucky enough to have 10 hectoplasm, we give it over a few seconds. So we don't start the thrombolysis when your blood pressure is 185. We start it at 180 over 105. Hypertensive urgency, how to reduce blood pressure 20% in the first hour. What is that? So we can use things like nifedipine commonly used. You can always go for an oral medications. Urgencies, you don't need to go for IV medications. Unless otherwise the blood pressure is very high, like let's say if it is 220 over 120 or something, you would still sort of keep them in a high dependency care and manage them. But if it is just a high blood pressure, no target organ damage, within the 20% drop can be achieved giving something like nifedipine. Do we have a Sri Lankan guideline to follow in hypertension management? So we are in the process of developing this. We do have a Sri Lankan hypertension management guideline. To Sri Lanka, there is a society for this, but for the ED management, there will be a guideline very soon. It's currently just in the assembling state. Can we take epistaxis as a feature of hypertensive emergency? Not really. Not really. Now, the bleeding from this highly vascular area occurs just because of hypertension. Generally, we don't take it as a hypertensive emergency. What about using GTN in ICH and CVA? Right. Now, it's not an absolute contraindication. I must say that it's not an absolute contraindication. Actually, the latest guidelines say you can use it. But the argument was that GTN causes vasodilatation. Now, ICH and CVS, as I explained before, already the cerebral pressure has gone up. So that was the sort of a pathological basis where we didn't use a vasodilator. We didn't use it as the first line. But if you don't have labetalol and GTN is the only medication, that's fine. When you bring down the blood pressure, this little vasodilatation effect will also be managed. It's not an absolute contraindication. In preeclampsia for pulmonary edema, NIV is beneficial? Yes, it is beneficial. In Sri Lanka, do we follow the new BP targets introduced by the American Heart Association? Now, we generally go with now this year, actually, we had the Hypertension Society. They had an update very recently. So if you just, I'll show you the reference at the end. There is a nice document done by this hypertension group. And if you read that, the BP targets are there. New hypertension management as outpatient, do we need to start to, not really. You don't need to start two antihypertensives at the same time. What is the treatment of choice in hypertensive eclampsia? So we go for IV labetalol. So same doses, we go for IV labetalol, 5 milligrams, 20 milligrams. We give it with magnesium. Right? Now, initially you start with a bolus, but these patients, they will end up having infusions as well. Right? First dose, give as a bolus. Repeated doses also you can give as boluses. Because why is that? Because your infusion, setting up an infusion takes time. Right? Right, I'll share the recommended reading for the hypertension. That's a nice guideline. If very high blood pressure with headache, do we take it? Yeah, we should. What they say is hypertension per se is not a symptom of, headache per se is not a symptom of hypertension. If a patient complains of a significant headache, you should consider it as a hypertensive emergency. What is the best drug? You can use any oral medication that is available to you. Prazosin may not be a good option, but like any other medication that you commonly use would be okay. Is it contraindicated to give stat doses in MI with SVP? No, stat doses are not contraindicated. It's the fibrinolytic. Stat doses you can give. Right, so we spoke about, now just give me a second, I'll show you. So severe hypertension in pregnancy, in eclampsia, we go 5-V labetalol. If you don't, you can go 5-V hydrolysine. If you don't have labetalol, especially peripherals may not have it, you might have hydrolysine. If you don't have either, go for methyl or nifedipine, whatever you have, and then you can actually inform before you transfer out these kind of patients, especially because now the fuel shortage has affected several patients. Several patient management has been affected by the fuel shortage. So it would be very prudent for the peripheral unit doctor. If they contact the relevant hospital, at least the emergency department, that hospital can take it from there. But one of these medical superintendents, one of the medical superintendents in the central province, what he told was he is actually happy to even send the ambulance to the peripheral unit to bring the patient rather than facing a maternal death inquiry. Right. Okay, so concomitantly we give IV magnesium. Right. So if you have labetalol, if you don't have, you give hydrolysine. If you don't have that, methyl dope and nifedipine plus magnesium. Right. Okay. Now, giving magnesium is not an easy thing. You must vigilantly look at the patient, monitor the reflexes, look for magnesium toxicity. So always get specialist opinion and get involvement of other teams when you initiate this treatment. Right. Okay. So finally, we'll talk about hypertension and the child. Because we were talking a lot about theory up to now, for this subtopic, I thought we'll talk about a case. And so there was a 10-year-old, previously well male, who was transferred to a central hospital, teaching hospital from a base hospital, pediatric ward. Right? The child is accompanied by the house officer and the mother. The transfer form, why the child was sent was for neurological imaging and further evaluation. Now, this is from a pediatric ward, not from a PC, right? So on the handover, what was told was this child presented with an episode of seizure, and they weren't sure whether the kid had fever or not. And while during this stay at the base hospital, there had been 2 further seizures. His white cell count from that day was 22,000. So they have started treating him as meningoencephalitis, ibuprofen, and acyclovir, weight-appropriate doses. And they have started him on full IV maintenance. But the child has developed some seizures now. They are presenting with a seizure, 2 further seizures, and sent for neuroimaging because of these further seizures. And now the child came with the house officer and the mother, right? En route to the teaching hospital to get the CT or neuroimaging. Now he has gone into a GTC lasting more than 5 minutes, right? And the house officer managed the child with some medicine. Okay, now this is in keeping. Now any seizure lasting more than 5 minutes is a status. Luckily, this happened quite close to the tertiary hospital, right? By the time the child arrived, by the time the seizure was starting and the 5 minutes, by that time, they were in the tertiary care hospital. Okay, right. So that was the handover. So we poked and asked some more details. And these are the actual pictures of the child taken with permission from the parents. Now, if you look at the child's eyes, there is some periorbital swelling. There is some ankle swelling, right? When we asked about the urine output, the child has not passed urine since morning. The first seizure has occurred around 4 o'clock in the morning. Since that time, this Baba has not passed any urine at all, right? So they came to the teaching hospital around 3:45 in the afternoon, around 4 o'clock in the afternoon. When we went through the ticket with BHT, there had been few readings for blood pressure like 130 or 101. There had been few more readings as well. So altogether, the child has now 4 seizures, 1 at home, 2 at the base hospital, 1 en route. Right? So he was given midazolam, was a little bit drowsy, but then his GCS improved to 50. Right. Now, what is this? Periorbital swelling and ankle swelling is edema. No urine output is oliguria. This blood pressure in a child is actually hypertension. So what are we dealing with here? Now we got few more details. Right? These are some cardinal things: edema, oliguria, hypertension. We ask some more details from the mother, and the mother says, yeah, this swelling kind of thing was there for the last 2 days. Child complained of severe headache yesterday, and their vision was all right, mother said, but they were concerned only when the child threw a fit. The previously well child, and the mother denied hematuria, but he has not passed since the morning, right? And when we look at the child, if you look at the picture, you can see there are a few scars like that, scabs, okay? Right. So basically, what are we dealing with here? So this is a child who is presenting with acute glomerulonephritis, presentation as a hypertensive encephalopathy. So airway assessment, airway was intact. When we stimulated the child, he could talk. He was able to maintain the airway. This is our general approach to any emergency, right? So we go by the ABCD approach. In the breathing, child was breathing at 26 per minute rate. Equal air entry, saturation was okay, 100% at room air. Pulse rate was all right. Volume was all right. Blood pressure is 130 over 101. Heart sounds were fine, no murmurs, right? Luckily, didn't have any neurological deficit. GC was 15 and AFib. On exposure, we saw that there was periorbital swelling, ankle swelling, and the child was in pain. Now, in children, it's always very important to get your weight. Otherwise, we won't be able to manage them in an emergency, right? So what happened now? If you look at the transfer form details, the reason for transfer was a neurological imaging, and their diagnosis was meningoencephalitis. But the cardinal thing that was lacking, I think, was interpretation of the vital parameters. Now, in adults, we are all very familiar with the numbers, right? But in children, how can we remember? Now, children, there are a variety of ages, then there are males and females, ethnicity is different. So how do we know what is hypertension? So one of the things that we did is, in the hospital that this child came to, the tertiary care hospital, they chart their blood pressure. They chart all the vital parameters for that matter. So we use pediatric early warning scores charts, which are age specific. Right? There are different charts for different ages. And we use all the vital parameters like respiratory rate, effort of breathing, oxygen saturation, then the Pu's. Now, these color coding is to correlate with the centiles. How bad is this number in this particular child, right? And we look at the heart rate, blood pressure measurement. So when you actually, then temperature and level of consciousness, everything we chart it. This actually happens. This particular chart that I'm showing you is from an Australian ED, but we use quite a similar one in the tertiary care hospital this child presented to. Now, if we actually chart this child's recorded blood pressure, this is how it looked. Right? All the readings that were there charted, this is how it looked. Right? Now, even though the number 130 over 101, it should have rang a bell, but even though it didn't, once you chart it, you know, okay, this is the normal. This is now age specified. This is now mentioned in a 5 to 11 year chart, okay? All the readings are in the red and purple segments. None of the readings are in the normal. White is for normal, yellow is for mildly elevated, moderate elevated. These are bad numbers. All of them are bad numbers. Now it's very evident, isn't it? Right. So how do we detect hypertension in children? Average systolic and or diastolic blood pressure is above 95th centile for sex, age, and height on 3 or more occasions. Now, we can't be looking at sex. charts, age charts and height charts, no? When the child comes to the ED. That is why these pediatric early warning scores are very useful. Now, with the shortage of paper, I'm pretty sure we can't print one chart for each child, but at least if we can have one set per unit, very beneficial, isn't it? You take the recording, you take the appropriate age chart and look at the reading, and then you can say, okay, this is bad. Or you can say, fine, this is fine. For this age, it's fine. Right. So otherwise, you could use centile charts. These are available. Centile charts are there in pediatric units, right? Just make sure you use the correct sex, age, and height. Again, taking the height in an emergency situation is a little difficult, right? Okay, then 3 or more questions. Now that is diagnosis of hypertension. So what is hypertensive urgency? You have severely elevated blood pressure without evidence of target organ damage, right? When we say severely elevated in children, we refer to the 99th centile, right? It's a crisis. Now, just like in adults, you have end organ damage, but the number itself is also high. You diagnose hypertension when the blood pressure is above 95th centile, emergency when the blood pressure is above 99th centile. Right. So, common causes for hypertension in children. Again, kids are a different set of species. So they've got newborns, you have the less than 6 years or the preschoolers, you have the school age, then you have the bigger kids. So it's again dependent on the age group. Commonly, they have renal problems, heart problems, and endocrine problems, right? So little tiny fellows, thrombosis, stenosis, pediatric, this polycystic kidney disease and things are common. Coarctation of aorta is common, right? Then less than 6-year-olds can have the parenchymal disease and vascular diseases, then endocrine things. School age ones, by this time, this heart and renal conditions are already diagnosed, right? Adolescents, now this is what we have to be aware of, right? More and more we are seeing younger CKD patients. So adolescents, you have to be very careful whether they are suffering from parenchymal renal diseases and drugs of abuse. Now we spoke about cocaine and amphetamines. So we have to make sure that our children, our adolescents who are actually under quite a lot of stress these days, we are seeing increasing number of depression among them, increasing suicidal attempts. So, and we don't want to miss this. This is a medical condition. So just be aware, right? So how do we treat them? Again, you need specialist opinion to treat them. I would probably, if they are not in an emergency, even if they're in an emergency, I would still contact the relevant pediatrician. And if I'm thinking of a renal disease, I would contact the pediatric nephrologist as well. Still, always go get specialist opinion when you're handling kids. For an emergency, you can just remember, you could use labetalol, hydralazine, and nifedipine. And you can give us boluses or infusions, but don't handle kids having pediatric emergencies by yourself. Always call for help, right? So generally, in hypertensive emergencies, now we said, no, adults, we go for reduce the MAP by 25% in the first hour. Now kids, it's different. We don't want that blood pressure to drop very fast. We drop the blood pressure by 25% over the first 8 hours. Right? Gradual reduction to normal value over the next 26 to 48 hours. So you can take a longer time to bring the blood pressure down to a normal level. So the particular child that I showed you all, so we catheterized him and he had actually hematuria as well. He went into a status epilepticus. He was managed with, he was actually given antihypertensives as well as anti-epileptics. And he ended up in the ICU for about 3-4 days and then handed over to the pediatric nephrology team. Right, so most important thing regarding children is it's important to take the parameters. Also very important to look at the normal range for the age and sex. Right? So in summary, So we have come to the end of the discussion today. In summary, use the correct technique to check blood pressure. If it is a child, or I think most of these multipara monitors that we have in PCUs and emergency departments, we do have the blood pressure cuffs that we rarely ever use. We have the cuffs, but we don't use them. So use the correct technique to check the blood pressure. And once you have the technique right, you can diagnose hypertension and hypertensive emergency. Always differentiate between hypertensive emergency versus hypertensive urgency. We do that by looking at the target organs. These target organs are starting from top of your brain, your eyes, your heart, and the major vessels, then your lungs and your kidneys. Use targeted blood pressure lowering therapy according to the clinical situation. True emergencies, we have treatment targets. Be aware of hypertension complicating pregnancy. Right? There can be a grid of diagnosis, and we will see more and more patients in time to come because they can't get to the major hospital these days, right? Always cross-refer pediatric blood pressure with age, sex, height, nomograms, or pediatric early warning scores. Right, so are there any more questions? We have gone through all the questions, right? Anything else that I can answer? So there were some questions sent by y'all beforehand also. So I have included most of the elements what you have asked in the presentation. I'm an emergency physician. I'm not a I'm not a medical specialist. I'm an emergency physician. So long-term management of hypertension, follow-up of hypertension, I have intentionally left out to be done by an appropriate person. Right then, thank you very much.
Thank you, dear Madam Dr. Tharanga Wijethilaka, for this informative and comprehensive lecture and answering all our questions. And please find the link to the post-assessment and e-certificate in the chat box, and we would like to get your feedback regarding this webinar. And once again, thank you, ma'am, for your valuable time and for joining us today, despite your time constraints, and hope to meet you again once with another session if time permits. And thank you all for joining us today, and hope to meet you again with another session next Sunday.
Thank you all.